As part of the upcoming International Day of Epidemic Preparedness, I'd like to thank you for this opportunity to share my public health experiences during the COVID-19 pandemic. These kind of forums are invaluable as we learn so much by sharing the challenges, ideas, and solutions, and there's continuous work needed to prevent and respond to these epidemic/pandemics at the local, regional, national, and global levels. So healthcare professional students played a big role from my perspective in the COVID-19 response here in the United States, as I am sure they did in other countries. It is great to see you engaged, since there's no doubt there's going to be other opportunities to respond to these type of disasters, and it's important to establish communication lines and share information and get these relationships established now. So a little bit of background about me. I retired from the U.S. Public Health Service Commission Corps. We're a uniformed service we're the federal component for public health. And back in 2009, I was on active duty during that time, and I actually responded to the H1N1 pandemic at that time. And at that time, vaccine was scarce. So I was on active duty during that. So I was deployed. We were focusing in general in the States on getting shots into arms. We had limited amount of vaccine. We had different formulations. And so we sort of got a little bit of taste. And that's actually where pharmacy sort of stepped up, because we were having a hard time trying to get the vaccine out. So I was very involved in that. And prior to then, we have a lot of training in incident command structure. We have training in responding to different scenarios. We're always having practices in responding to disasters and things like that. A lot of hurricane response. We had Ebola. Anytime you see something in the news, the chances are we were there. So within about a year after I retired, so it was on March 13th, 2020, that's when the US president declared the COVID-19 response was a national emergency. But prior to then, this is in January, we sort of knew what was coming. As soon as we started hearing things, it was January where I clearly remember. What happened is even though I was retired, I reached out to the folks I'd worked with in the previous pandemic and said, hey, it looks like there's something coming down the pipeline. So some of us started getting together and meeting, and I'll talk a little bit about that in a minute here. So once the president declared the national emergency, though, that triggers a whole bunch of things at the federal level. So there's a lot of vehicles and statutory authority that is used by the federal government to issue these emergency declarations. And one of the things that they do is they activate a national response framework, which really enables the domestic response partners at all levels to really start working on providing a uniform response. And there's just a lot of different agencies that are all of a sudden get engaged in this. And one of those is this incident command structure, which we knew needed to be in place because it doesn't work if you don't have this structure in place. And command structure for coordination, for information flow, for analysis, decision-making, communication, and just implementation in an authoritative and standardized manner. So over the years, we've had plenty of practice doing this. I will tell you though, this infrastructure that we had been trained and it was supposed to be in place didn't work as well as everybody thought. So I know that because I was retired, I could be on the outside, and what I was involved with, and I'll just kind of go through and tell you my experiences. What I got involved with, remember, I got together with that group and we started meeting. We pulled in the players that we knew needed to be engaged. And there's different organizations that are part of all of that. And we called ourselves the Navigator Group. And what we were doing is we were all listening. Some people were in contact with CDC. We were in contact with different groups. I was in contact with the Operation Warp Speed folks. So we were talking to different people in the different agencies. The agencies in the US that are involved are the CDC, NIH was involved, the HRSA, was involved, FDA, HHS. These are all groups that were involved, and there's a lot of coordination going on. And then there's the public health groups at the state level and local level. So all these groups, we were trying to figure out, okay, what are you hearing? We were trying to listen to hear we're hearing. We knew what needed to be done, but we also knew that decisions had to be made for us to move forward because of that incident command structure. You know, we needed a way. You know, where do we get the testing? How can the testing be done? How do people find the testing? Let's start out with testing, and then later on we started gearing up for vaccines, and then later on for treatment. So all these things were going kind of in movement. So we had that one navigator group. We got together, and that group is still meeting to this day. Just so you know, they meet every week and just talk about different issues and what everybody's hearing. And a lot of it is real. The pharmacy groups are doing. I spent time working on where we thought there might be holes, and just making sure that people were thinking about about areas. So an example would be for the vaccines. One of the big concern is we knew the reimbursement rates varied for vaccines across the nation by states, by payers. Some covered things, some didn't cover. This is for just regular vaccines. So we were really concerned that there was going to be disparities between people that were eligible for could get the vaccine, and people that couldn't. We wanted to have input on who should be getting it first. So we were meeting 2-3 times a week during all this time, visiting with this. We actually had a medical student that helped put together a list by state for our Medicaid program, which is really the folks that are underserved in the states, and put together a list showing that the disparities between the vaccine administration rates that were given throughout the country. And that information was shared with CMS, who is the payer for oversees, they provide all the policy for the payment part. And we shared that with them. So we were really pleased when they tried to make it across the board. They encouraged, you can't mandate, encouraged everybody to use a rate that they came up with. Now that rate initially was put out, and it was increased later on when they found out it was a little bit more costly to incentivize the providers to be able to get those shots in arms. So anyway, a medical student was key in doing that. The other thing that was involved a lot is the students, the healthcare professional students. This is nursing, pharmacy, medical. Were very, very engaged with a lot of these mass vaccination sites. They were involved in a lot of the testing sites. They were really good labor, very supportive, and they kind of mixed in with other groups. In the United States, we have several different groups. We have folks that are actually paid for emergency response. We have our Commission Corps colleagues. We actually have a strike team that's involved in things. They can go on a moment's notice and be somewhere. And then I was actually personally part of the Medical Reserve Corps, and that's a volunteer group. And they all these groups provide training, but they needed help. They needed help drawing up doses. They needed help with just giving doses. So in these situations, I end up being a gap filler. I'll go wherever is needed because I can do any of the jobs that are there, or I can learn pretty quick if it's something brand new, like a new software system. So that's what I ended up doing, is helping quite a bit early on, and just with all these max getting the shots, they needed people to do it. And I will tell you, it was one of the most rewarding experiences. Somewhere in the middle of all of this, we had our ears open. We knew that there were some challenges with the seniors, people in assisted living, people that were in these rural areas, people that were just not in other words, they were going to be a little bit more work. Some of the groups were easy to get vaccinated. They had already made that decision, they were going to do it. Other ones were, there was language, they didn't understand what this is about. We had to have a different strategy. So in putting together, several of us got together and put together different strategies. And I know nursing homes was another area. And so we were meeting on a really regular basis. And what the most important thing that we could do is hear what's going on, boots on the ground at all these different levels. And from across the nation in different states, different counties, and listen to it and what the challenges were, because people were trying to do the right thing, but sometimes the regulations didn't allow them to, or they didn't have resources. So listening to all this was really, really important. And I know that like CDC was on a lot of these calls listening, because they were trying to put out as quick as they could policy and things like that to address some of the challenges. An example is one of the areas was they were, for the quarantine, if somebody had, at the state level, had made the decision, if somebody was positive for COVID, then everybody had to be quarantined and no visitors. Well, as we all know, just someone that is senior and being separated from people and not being around anybody, that's, we've got to weigh the pluses and minuses of that. So we had lots of input, lots of discussions on that, on how to address that, so people could interact with other human beings. We had this group, even to this day, it started right when COVID started, it's still meeting to this day. There's still issues going on, and COVID is still around, so we're still addressing that. Another area that ended up spending a lot of time on was misinformation, disinformation. It started out with just people having information, and you go look at it and you realize there's this mixed in with this accurate information was misinformation, and this was getting put out on social media quicker than we can keep up with. I know that people would send it to me, then I'd go research it for a few days, but by the time I'd get the answer, it was already on to a different topic. We couldn't respond quick enough. I actually was able to be part and help and provide some speakers and direction for a PBS, which is a public broadcasting station program. It's called, they put together a PBS program called the Misinformation Virus, and they put that out, and I helped, get that out nationwide. And of course, we highlighted students in there because the students were very, very helpful in providing education and trying to educate people. When we go look at the history of these pandemics, what we experienced in COVID was similar to even back in like with the flu back in the 1918. Just the disinformation, misinformation, people get scared, and it's just that it sort of blew up because of all social media. So it was a lot more challenging here with social media and influencers and things like that. So anyway, addressing misinformation was a big area. I spent a lot of time on there, working on the strategies for the different populations. We wanted to make sure we were getting farm workers, we were getting people in rural areas, we had interpreters. And then through all this, we started collecting and having these model programs that were out there, people that just took the initiative, work with their public health programs, their local public health or county or the state public health departments, and had these great programs, these mobile programs going to the residents, to consumers, to patients, out in the field, and anyway, addressing all of that. It was actually very heartwarming to see the creativity out there, and how people had worked together, both private and public partnerships working together to move forward on these. I will tell you, before the COVID vaccine, we started practicing. We knew what was coming up. We used to do this all the time back when I was active duty. We would practice our mass vaccinations for the flu vaccine. We'd practice with that. So working with the churches and working with employers and working with the local schools, we would work together with all of them. And those relationships that got established during COVID are continuing. And it's really great to see them continue this. So where do we go from here? So there's a lot of work that needs to be done. This same memorializing, getting this documenting, getting the infrastructure established, getting all this infrastructure established. We did the same thing in 2009. We're going to do this again, and we've got to figure out a way to keep this going so we don't forget in 10 years, because it's going to be different people involved, different leadership, and so we need to figure out how to keep this going. I know one of the areas that we're continuing to work on is we have a group of independent pharmacies, and there's like 21,000 of them in the United States, and they are mainly in these underserved rural areas. And they're mom and pop pharmacies. And so we're working right now to figure out so they can have one voice and be at the table, because that was one of the challenges. They serve they fill so many gaps in providing care, and they know their patients so well. We need to make sure they're always at the table. And so that's one area that we're continuing to work on. And I know the CDC and HHS and everybody is still working on trying to get this infrastructure in place and have enough funding in place to kind of keep this going. What really is good to happen is have these practices. I will tell you, going through and having either using real situations and implement that incident command structure and do that, having real situations, or having practice ones where we all figure out how to work together. That's actually key, because then you learn where the holes are, where our gaps are, and what we need to work on. And we need our leadership to prioritize to make sure that we don't, that we continue to work on some of these. One of the big areas right now that all of us need to work on is trust. The trust in the healthcare system. People don't trust it anymore. There's a lot of distrust with all the information that got put out, and they know we're changing our mind, masks or no masks. All of that happened, and we need to find ways to educate and build that trust. And I know one of the ways to do that is for each of us to develop these relationships with our patients, so they have somebody to go to that they know and that they've developed trust over time. Trust doesn't happen with one visit. Trust happens over time. So that's a really important component, not only for an epidemic or a pandemic, but for healthcare in general. So anyway, I appreciate the opportunity to spend some time with you and to share a few words of wisdom. I think this is a great opportunity to hear everything. Obviously, if you want to know more information or have more details on any of these groups or organizations, we have both nonprofits, for-profits, we have federal government involved, all working together. And we have really good people that really want to make a difference in their communities. We were able to make a lot of change. So anyway, thank you very much. And I appreciate the opportunity to spend a few minutes with you.